Good morning, sir. Should I start, sir? So this is clinical grand round for the Department of HPV and LT Surgery. Uh, First, we are going to present the activities on liver transplantation for acute liver failure in the department, followed by literature, and followed by the technical aspect and video presentation. Coming to the donor characteristic, we will start with the donor. The median age of the donor is 21. Total number of liver transplantation for acute liver failure, including both pediatric and adult, is 133 patients. And donor age, the median age is 28 with a range of 21 to 49, that is interquartile range. And majority of the donors are female. Majority of them are first degree relative, which is 76%, and DDLT accounts for 3%, that is 4 patients has been transplanted with diseased donor liver transplantation. The type of graft for both adult and pediatric, which we are going to see in both adult and pediatric separately also later on. The right lobe without MHV is 48%, and left lobe graft is 33%, and left lateral lobe is 15%. And this is donor 3% of the patients. This is the donor characteristic, that is liver attenuation index. BMI is 24.3, and cumulative blood loss per case is 440 ml. Peak post-operative bilirubin is 2.83, INR 1.8. Hospital stays on an average 7 days, and follow-up of these donors are till 36 months. And the most important thing is evaluation time. When the donor first came to us for evaluation is 14 hours. Within 14 hours, all the 3 steps of the donor evaluation was completed. And depending upon the patient clinical status and indication, the timing, then transplantation happened. Clevin-Dindot classification for the donors, more than grade 3B complications. None of the donors had more than grade 3B complications. Coming to the recipient characteristics, the pediatric transplant happened for acute liver failure 73%. This data is till 2025 December, and adult patients 60 patients. Median age for the pediatric patient is 9 years, adult 33 years with interquartile range of 16 to 53, and the female recipients are 42% in adult, in pediatric, and almost 58% in the 58% of the recipients are male patients. And similarly, in adult patients, 64% are male patients. So most of the recipients were male, whereas the donors were female. Approximately 60% of the donors were female. According to the jaundice to encephalopathy time, the categorization of acute liver failure, that is hyperacute liver failure, acute liver failure, and subacute liver failure, most commonly they presented with like acute liver failure, and almost 1/3 of the patients had hyperacute liver failure, and approximately 10% of the patients had subacute liver failure, which is also very common in our setting, particularly drug-induced liver disease or autoimmune and indeterminate variety. They will present like subacute liver failure. Coming to the etiology specific, most common etiology we faced are hepatitis A, both in pediatric and adult. In pediatric, hepatitis A is a little bit more compared to the adult patients, followed by hepatitis E. And other etiology accounts for 15.7%, which includes Wilson's disease, autoimmune, and drug-induced liver injury. And one thing which is specific to our part of the globe is ATT-induced etiology, ATT-induced acute liver failure, which is approximately 10%. And one important thing is indeterminate also accounts almost 22.5% of all the transplants, and similar distribution between both the pediatric and adult patients. Coming to grade of encephalopathy, most of the patients had grade 3 or grade 4 severe encephalopathy, which is 76%. more commonly in pediatric, which is 82%, and in adults, it's 70%. Um, Almost 90% of the patients had a preoperative ICU stay. The need of mechanical ventilation was to the tune of 83%. The pre-LT mechanical ventilation days is approximately 2 days with interquartile range of 1 to 4. Coming to other parameters at the time of admission, that is serum sodium level and ammonia. Ammonia level in pediatric patient is 227 on an average, the median value, and the adult is 312. Total bilirubin level, these are all highly jaundiced patients, 20 bilirubin in pediatric and 25 in adult. PT-INR value is quite high, 4.6 and 4.17. Almost 50% of the patients had SURS by definition at presentation, and 30% of the patients had shock with vasopressor support. Clinical cerebral edema was present in 20% of the patients, and cerebral edema documented on CT scan was approximately one-fourth of the patients. Coming to the sepsis part is also very common in our setting. That is, most commonly the source is ET secretions and the bile culture positivity. On these patients, almost 50% of the patients in pediatric and 30% of the patients in adult patients, they had plasma exchange before being considered for liver transplantation. The vasopressor support was almost 30% of the patients. Dialysis and CRRT, predominantly in view of hyperammonemia, is 31% of the patients. Time to transplantation from admission, median time is 48 hours after the first referral for liver transplantation. Most of the patients, they satisfied KCS criteria. Even almost 30% of the patients, they had single criteria satisfaction in pediatric, and 20% of the patients almost they had satisfaction for single criteria in adult patients. And 2, 3, and 4 criteria, most of the patients satisfied either 3 or 4 criteria of King's College criteria. Coming to operative details, that is the graft type. The common graft used was right lobe without MHP, 48%, followed by left lobe, subsequently the left lateral and DDLT. In pediatric patients, the common graft that was used is left lobe graft, which is 41%, followed by left lateral, and equal number of right lobe graft too. In the adult patients, obviously the right lobe graft was more commonly performed in these patients. GRWR average is 1.11 in pediatric and 0.92 in adult patients. The cold ischemia time, warm ischemia time is almost kept minimum, and by balancing the both recipient and donor operations. The blood loss is 710 in adult and 1300 pediatric, and 1350 ml in adult patients. Operative time is shown 680 and 740 minutes. Coming to complications in recipients, grade 1 complication was seen in 5.6% of the patients, grade 2 complication 41% of the patients, among which the most common complications are sepsis, acute cellular rejection. One of the important things we should highlight in our setting is critical illness neuropathy, which is seen approximately 13% of the patients in pediatric and 4% of the patients in adult patients. And this is because of pre-op mechanical ventilation and ICU stay, and subsequently a delayed awakening in those patients and having critical illness neuropathy. Coming to grade 3A complication that was present in almost 12% of the patients. The type of complications are pleural effusion needing drainage, SSI, liver biopsy required for various reasons, including the acute cellular rejection, early bile leak, or portal vein stenting, which was required in one patient only. And hepatic artery thrombosis is very rare in this cohort, and angioembolization because of some bleed that was also required in one patient, in pediatric patient. Coming to grade 3B complications, that was almost presented in 11% of the patients. among which tracheostomy in view of critical illness neuropathy and prolonged awakening and prolonged period required in ventilation and ICU stay. Those patients may require tracheostomy. Re-exploration for HAT is 1.3% of patients only. ERCP and stenting for biliary anastomotic stricture only in two patients. And re-exploration for bleeding, debridement, and dilatation, evacuation of residual conception product in one patient in pregnancy induced acute liver failure. Grade 4A complications happened in 8.4% of the patients, whereas grade 4B in 7% of the patients. Among these, the most common reason for grade 4A complications are cerebral edema or sepsis. Coming to grade 5 complication, that means those complications leading to death in the recipients happened in 14% of the patients. And a common scenario is sepsis and MOTS, multi-organ dysfunction syndrome, and diffuse cerebral edema with or without intracranial hemorrhage, also one of the common cause. Severe acute rejection, and 3 patients are intra-alveolar hemorrhage because of persistent coagulopathy, allograft dysfunction, and biliary anastomotic stricture. Those were the causes for death. Coming to factors predictive of post-transplantation mortality in adult patients. So these are the factors which we analyzed among the survivors and the non-survivors. Among all the factors, as you can see, the parameters which are responsible for or can be attributable for mortality. One is SERS before being transplanted, and the other factors are positive culture. Sepsis definitely determines the post-LT course. And among the operative factors, cold ischemia time came out to be significant. And post-operative factors, persistent brain edema, which was there in pre-transplantation period, and pulmonary complication. These are the main factors, along with the neurological complications. And these are the factors which contributed to mortality in adult recipients. Coming to pediatric acute liver failure, the factors affecting the mortality. Cerebral edema, persistent edema is one of the factors, along with ammonia level came out to be significant, contributing to mortality. Pre-LT mechanical ventilation more than 24 hours, which is a very important factor, is responsible for, contributory to mortality. Along with SERS and positive culture, sepsis is one of the constant factor modifying, attributing to mortality in both adult and recipient. Among the post-operative factors, persistent brain edema, AKI, and pulmonary complications, and sepsis. All those obviously contribute to mortality. Coming to overall survival in adult patients, if we look at 1 month survival, it's 76%, and 5-year survival, 1 year survival, it's 66%, and 5-year survival is 64%. With a long-term follow-up, 10-year survival, it's approximately 60%. And pediatric transplantation and the survival is quite encouraging, which is 88% 1 month survival. 1 year survival is 75%, and 10-year survival is 70%. Now I will hand over to Dr. Sahil for regarding the literature and
Nihar, before you leave, can you go to your other